Okay, the genitourinary system. So basically, this is going to cover both the genital region for both male and females and the urinary system. Okay, so just a simplistic overview. We have the adrenal glands, which are situated on top of the kidneys. We have the kidneys. On both left and right side. Notice that the left kidney is higher than the right side, and that's because of the liver. Also, we have aorta with celiac trunk or celiac axis. Then we have the superior mesenteric artery, and then as we come on down, we have the inferior mesenteric artery. We also have the vena cava here, and in this case it is the inferior vena cava, so it's the IVC. We do have the bifurcation here, which splits into right and left common iliac arteries and right and left common iliac veins. And then we just continue down until we get internal and external iliac arteries. We also have the bladder here, and leading to the bladder we have the ureters traveling in this path here. Then we also have the urethra, and depending on male or female, the urethra may be very long or very short. Males are very long, females are very short, and so that will lead us to certain types of pathology as well. And let's continue on, and here is an overview of the kidney. We have the capsule, which is the tough outer layer, and it's called the fibrous, and that's because it's tough outer layer. It's kind of a fibrinogenous tissue. We have the cortex residing in this area, and then we have the medulla, which is basically this area here in between. I know that this says that this is the medulla, but we also have this area here as well, confirming the medulla. So then we have major and minor calyces, and the way that you can keep these straight is the minor are this area here. And the major calyces are where the minor calyces actually go and merge together. So you have 3 minor calyces going into a major calyce here. And so that's typically what you're looking for. Here we have a major calyce and minor calyces here, major calyce and minor calyces here. Both the major and minor calyces come together, and after the major calyces exit, we see that they come down and converge in an area known as the renal pelvis, which is going to be this area. We see a lot of stones actually get lodged in this area here, where they're attempting to go down the ureter, but they're lodged in the pelvis. Then we continue down the ureter, and as we continue down the ureter, then we get to the UVJ, or where the ureters meet the bladder, and that's where a lot of renal stones will be lodged as well. So it's important to know these structures so that you can better demonstrate actually what the kidney looks like, and you can know what the kidney is actually look like if you see some pathology. So Let's begin by looking at just some congenital abnormalities. Congenital, as we all know, means at birth. Okay, and so we have several things. We have unilateral renal agenesis, and as the name implies, uni means one, and so we have one kidney, and that's what it actually is, a solitary kidney. I notice that it's very rare, so that's something that you're going to notice right off the bat. And it's associated with a wide variety of other congenital malformations, and it results from a failure of the embryonic renal bud or renal vascular system. So basically, the kidney just doesn't develop. Okay. The solitary kidney tends to be larger than expected, but compensating for hypertrophy. Um, so basically, your other kidney is going to be large. And so that's something to keep in mind. It's going to result in one large kidney. So it's trying to compensate for what the other portion of the renal system is not doing. Also, we have a supernumerary kidney, and so super means above, and numerary means number. So above the normal number of kidneys, which is an extra kidney or a third kidney. The thing about this is the third kidney is usually small and rudimentary, meaning that it really doesn't serve much of a purpose. It's really too small. It's got a lot of atrophy, just doesn't function very well. And it even possesses a separate pelvis, ureter, and blood supply. So pretty crazy to see someone with 3 ureters instead of just 2. Typically causes secondary infections that eventually require removal. So typically, you may not even actually see the third kidney because the patient has had it removed. So that's something to keep in mind. Requires removal because of other infections and other abnormalities that can come about simply because of it. Another abnormality is a hypoplastic kidney. Hypo means below, and so if we take that root word, we see that it's below normal or below in size, and it's called a miniature kidney. It appears as a small replica of a normal kidney, so it looks like it has all the structures, everything of a normal kidney, and it even has good renal function. So it still functions like a normal kidney. Has normal relationship between the amount of parenchyma and size of the collecting system, and so everything is just scaled down, but it still functions. And so you may actually see these, and sometimes you'll see people that have atrophy, their renal system, have a kidney that's actually smaller. Ectopic kidney. Ectopic, as we think of like an ectopic pregnancy. An ectopic pregnancy means that the pregnancy is not taking place where a normal pregnancy would be. Most of the time it's in the fallopian tubes, things like that. So it's abnormal, and it's abnormally placed. And so if we apply that to the kidney, we see that it's abnormally positioned as well. You can have several things. Pelvic kidney, which is a kidney located in the pelvis. Intrathoracic kidney, which is located above the diaphragm, which is pretty crazy to see. Crossed ectopia, both kidneys lie on the same side. I've actually saw a pelvic kidney. It's pretty wild. When you see a person that has a kidney as you're going down into the pelvis, you pass the crest, and there all of a sudden is a kidney. And the ureter is very short. This patient that I saw this pelvic kidney on, she had a history of renal stones, and they were often on the side that she had the pelvic kidney on, and she was having tremendous problems actually passing the stone. Required surgery several times. But her kidney was also mal-rotated, meaning that it wasn't rotated like a typical kidney, but it was rotated the opposite of a typical kidney. Very strange to look at, but I imagine that an intrathoracic kidney would be one of the craziest things to actually see. But once again, these are very rare. You might see slight abnormalities in position, but these are all going to be very rare. So you may see one and you may never see one. That's just kind of the way it all goes. You may never encounter one. Another one is a horseshoe kidney. This is the most common type of anomaly, and I've actually seen one of these as well. And both kidneys are male rotated, and their lower poles are joined by a band of normal renal parenchyma. So the kidneys have an appearance something like this, with an indentation here, looking similar to a horseshoe. Ureters arise from the kidneys anteriorly, not medially. And so the ureters, if you're looking at it, they would come anteriorly and not typically medially like you would see in this case. So anteriorly, not medially. That's something to keep in mind. Lower pole calyces point medially rather than laterally. So once again, they are male rotated. That's something you want to keep in mind. But you're typically going to notice a horseshoe kidney because it's the only type of abnormality where you're going to see both joined together. Also, we have duplication, which is a common anomaly that may vary from a simple bifid pelvis to completely double pelvis ureter. And so basically, you can have dual renal pelvis, or you can have dual ureters. Either one of these would be basically what we would call duplication. So either way, this is typically what you're going to see. Ultrasound and plain X-ray films are the preferred method of diagnosis for this. Once again, plain X-ray films are just not simple plain X-ray films. We're talking something like an IVP so that you can actually see the renal collecting system. The reason CT is not the preferred method of diagnosis is because sometimes it's really hard to trace in terms of CT whether we're actually seeing ureter or it's another vessel. And so if you were doing a CT, you would have to have with IV contrast. So keep that in mind. A CT without IV contrast is not going to be much help at all. So you definitely need a CT with IV contrast for this. Glomerulonephritis. Basically, it's a non-supportive inflammatory process involving the tufts of the capillaries that filter the blood within the kidneys. It represents an antigen antibody reaction, and it generally occurs several weeks after an acute upper respiratory or middle ear infection. So that's something to keep in mind, that glomerulonephritis occurs usually after upper respiratory infection or a middle ear infection. Kind of strange. And it's correlated with certain strains of hemolytic streptococci. And so basically, it's because these things all tend to share the same bacteria. Kind of crazy in that respect. And it results in proteinuria and hematuria. And so proteinuria means that you have protein in the blood and or blood in the urine. I apologize for that. Proteinuria means protein in the urine, not blood. Of course, you're going to have protein in the blood. Lab results display a decrease in glomerular filtration rate. We talked about GFR in some respect, and GFR is going to be basically how your kidneys filter the blood. And so you want to keep that in mind. That this is going to be how the kidneys are filtering the blood. And so if you have an increase in glomerular filtration rate, that's great. But if you have a decrease in glomerular filtration rate, it means that your kidneys really aren't filtering the blood to an effective level. And so basically, if you have a decrease in glomerular filtration rate, it means that you're going to have a small amount of urine produced, because the kidneys really aren't taking any of the waste out of the bloodstream. So it's very important to actually see this. Okay, pyelonephritis. This is typically what you're thinking of when you have a kidney infection. And so many times this gets lumped into just a generic term, a kidney infection. And so we see that this is actually an inflammation of the kidney and or renal pelvis. And so either one of these will suffice. It's caused by pyogenic bacteria. And basically, pyogenic means that it's pus producing. So that's what you're going to see. Pus producing bacteria actually cause this. And it affects the interstitial tissue between the tubules. It originates in the bladder and ascends by means of the ureter. So this is something that you want to keep in mind, that it originates in the bladder, and then it climbs somehow up the ureter. It progresses through the ureter, and then basically attacks the kidney. And so there would be several hypotheses based on this. Does it decrease the amount of urine that's being evacuated through the bladder due to the fact that it's producing pus? And then it allows the renal system to basically back itself up. And so because of that decreased urine production, it allows it to ascend up the ureter. That's something that would be excellent to be analyzed. But we also see that it often occurs in women and children. And by often we mean that usually it's most common in both of these. That's not to say that it cannot occur in men, but that it's less likely to occur. And that's simply because of what we've already discussed. Women have short urethras, which means that it allows it to get into the bladder very rapidly. And so any time that it can actually get into the bladder, then it has an excellent chance in actually making it to the kidneys. And so men have a longer urethra, which means that it's harder for bacteria to actually make it into the bladder. And so that's typically the reason there, and much the same for children as well. The symptoms, we can see that we have high fever, chills, sudden back pain. A lot of times this is what gives it away. This is the most common symptom that people just experience, a low back pain that they're not really familiar with. They don't have any history of injuring their back, and so typically they see that there's something going on. Also, dysuria. You have difficulty urinating. A lot of times you see this where patients they feel the need to urinate, but they really can't. And once again, that can be because of the pus-producing bacteria. And also pyuria, which means pus in the urine. And based on the type of bacteria, we see that wouldn't be uncommon either. And so many times if you see patients give a urinalysis, or you see the samples of the urinalysis, then you're typically going to see a very thickened urine that looks like it has mucus or pus in it. It's just going to look really, really nasty, and that's typically what you would see with pyelonephritis. Also, cystitis. We know that cyst means bladder, and so this is going to be a bladder infection, and so we see that it's an inflammation of the urinary bladder. It's more common in women than men. Once again, women have short urethras, and that is really what is going to affect us here. The causes are inadvertent spread of bacteria present in the fecal material, which reaches the urinary opening. So while it sounds kind of gross, fecal material has a tendency to make its way based on the close proximity to the urethra, which somehow the fecal material, we won't go into detail how it can reach there, but fecal material actually makes its way to the urethra and it reaches the urinary opening and then has the ability to inflame the bladder because of a decreased length of the urethra. But also, you see this quite common too, urinary catheterization, which allows bacteria to travel up the urethra. But typically, the urinary catheterization, the bacteria has to be present. So usually the bacteria is already there. It just needs a way to get into the bladder, and urinary catheterization offers the right means to do that. So if we move on from the urinary inflammatory processes, we actually are going to talk about renal stones now. One of the most common things that you'll do a CT for, actually it is probably the most common exam that you'll do, arguably against a CT head. But depending on your population density and the type of patients that you have, you're going to see a lot of patients that either have a history of renal stones, or you're going to have a suspected renal stone being lodged somewhere. A lot of the times this is bore out by urinalysis, which then prompts a CT to look for renal stones. But if we can just look at the description, we see that urinary calculi most commonly form in the kidney. So that's going to be where it's going to form. Very rare that it's going to form anything anywhere else. And most of the time, patients are asymptomatic until they lodge in the ureter and cause partial obstruction. So what you're waiting on is the partial obstruction. That's where most of the pain comes from, because of the backing up of the renal system. That's where you have hydronephrosis, things like that. And that results in extreme pain that radiates from the area of the kidney to the groin. And so basically it reaches from the kidney to the groin quite a long distance. So if we look at what causes kidney stones, we see that there are several different supposedly underlying factors that could cause this. Most common is an underlying metabolic abnormality. So you want to take note that it's a metabolic abnormality such as hypercalcemia, which is high blood calcium. Hyperparathyroidism, so you have an overactive parathyroid. Okay. Also, any other causes of increased calcium in the urine. So anytime that you have increased calcium in the urine, that can lead to a pooling effect in the kidneys, and somehow all of this calcium just seems to form itself together. Another thing is urinary stasis. So if you have urine that you're just not able to evacuate, that can cause the metabolic waste that's being filtered through the kidneys to actually form a stone. And also prolonged infection. So you have just a history, or a notorious history, I should say, of renal infection, then somehow this can cause a renal stone as well. But typically we favor this one, where there's just a metabolic abnormality, and that is what has caused the renal stones. But that's not to say that other means are not out there as well. Typically, patients present with pain that can either be in their back, and it can be radiating. So it can be radiating, or it can be flank pain, usually to a particular side. And usually The patients will tell you that I've had stones on this side before, things like that. Also, nausea and vomiting due to the pain. This kind of depends on the patient's pain threshold. How they tolerate pain will affect whether they're nauseated or not. I've seen patients who are throwing up and they're just breaking out in a cold sweat, and it's a very, very small stone. I've seen patients with basically a staghorn calculus, and them not be in a whole lot of pain or not be vomiting or nauseated at all because of the pain. So it all depends on the patient's pain threshold. Hematuria, once again, blood in the urine. That's one of the most telltale signs. A lot of times it provides an excellent indicator that the stone is trying to move or trying to progress, because it's kind of ripping and tearing its way down. And then also painful urination. But this is kind of a misnomer, because this can be construed as a renal infection as well, or a cystitis. So there's several different infections there. So this could possibly be infection here, and so this is kind of a misnomer. So you really can't base everything for a renal stone on just painful urination, because there's so many other things that can be as well. The workup for renal stones. First, you're going to order lab test. You're going to order a CBC first, which is going to display an increased blood cell count. This can be an indication of some type of inflammatory response, or inflammation, or an infection. Then you look for a comprehensive metabolic panel, which is going to display an increase or a decrease in BUN, and an increase or decrease in creatinine levels. Also, you're going to pay attention to GFR on this as well. Also, we look at UA. In the UA, we're going to have maybe some lymphocytes or leukocytes. And if we have leukocytes, in the blood, that's typically what we're going to know as an inflammation. Or if we see blood, that's going to display that we probably have a renal stone here. And then from the lab test, we have two different possibilities that we can actually utilize. We can either do an IVP or CT abdomen pelvis without. Used to be in the older days of radiography, this was your go-to exam. Your IVP was pretty much good as gold. But now we have the capabilities of imaging the patient very rapidly, getting a diagnosis very quick, and allowing treatment to begin for renal stone. And so potentially this is your best option, and I favor that as well, because ultimately by the time that you get done with the IVP, you've injected the contrast, and then you've also took several pictures, and the patient has had to wait in the x-ray suite for quite a while. It seems that CT abdomen pelvis without contrast is very, very accurate for this. And also, you have the capabilities to measure and define precise location. And so, due to the precision for CT abdomen pelvis without, we typically think that that is the best option here. So, typically you're going to go from lab test straight into an abdomen pelvis without. Also, an important thing to keep in mind here, if it is a female patient in childbearing age, many times a pregnancy test is going to be ordered too, because sometimes pregnancy can actually mimic this pain and symptoms, especially if this is an unknown pregnancy. So you definitely want to make sure that pregnancy is factored in, and that you verify that the patient is not pregnant before you actually scan the patient. So what you're going to see in terms of CT is kind of different depending on what type of stone it is. You typically want to use non-contrast helical CT. Helical CT for the speed, and non-contrast so you don't obscure. So the last thing you want to do is obscure, and so you want to eliminate that. CT is the most frequently used to best demonstrate the stone without anatomically obscuring the area. It offers us the best representation of the renal stone. And so that brings us to the type of stones. Typically we all just kind of lump renal stones into one category, but that's not to say that all stones are created equal. We have calcium oxalate and calcium phosphate. Notice here that the key word in both is calcium. Calcium increases the density, and because of this, it's 73% of all stones. CT attenuation is going to be the most for this type of stone, being around 800 to 1,000 Hounsfield units. So the thing that you want to keep here is that they're going to be bright white. More so than all the other stones because of the amount of calcium that they have in it. And notice that this is the most common. And so typically that is going to be what you're going to see. Also, we have struvite stones, which are 15% of all stones, and they're seen with chronic infection. And so typically they're the result of chronic infection. And notice that they can be ranged from 300 to 900 Hounsfield units. So pretty much they're not as dense. That's something to keep in mind as well. Uric acid stones, which are 8% of all stones, and have the attenuation of around 150 to 500. So we're decreasing in our density here, and they're only 8%. And so they're formed by uric acid. So we know that uric acid can create a lot of problems, can increase the prevalence of gout, and because of that, we can also see that uric acid will cause stones as well. And then last is cystine stones, which are perhaps the least common of all stones, have an attenuation value of 200 to 800 Hounsfield units. But typically, you're not going to see somebody measuring what type of attenuation factor. It's something that you could do, and I would say for your quiz or exam, you definitely want to know the Hounsfield units for all of these. But typically in the clinical setting, you're not going to be sitting around measuring what type of stone it is. If you wanted to impress a physician, that would be an easy way to do it. That you could say, well, I measured this in Hounsfield units, and I'd say it's probably this type of stone. But in a clinical setting, it's really not about what type of stone it is, but rather what you can do to get that stone to pass. That's typically what we're more worried about. And then once the stone is passed, then you can really worry about what we can do to prevent these stones from occurring again or decrease their likelihood. But these are typically what you're going to see. And so virtually all stones, even those that are radiolucent on plain film x-rays, are identified as high attenuation foci on CT. So that's what makes CT so much better, is that we can see virtually every one. Okay. CT can identify a stone that is 1 millimeter in size. So you can see just precalcifications. You see a lot of times that there's these precalcifications inside the kidney, and that's typically what you're looking for. You see precalcifications, and you're thinking that maybe they can become a stone pretty soon. Also, ureteral calculi are usually geometric or oval in shape. Usually, if they're in the ureter, then pretty much they're going to be nice and smooth and round. They are rarely completely round, which is useful in delineating between a renal stone and a phlebolith. And so typically you're not going to see a nice round stone, but they're going to look more oblong like this. And so usually your Phlebolyths are going to be more round, and renal stones or ureteral stones are going to be like this. And so that's going to be a way that you can tell them apart, because sometimes it gets confusing where a ureter is and where it isn't. The burden of stones in the kidneys is easily determined by CT. Stones are seen in the region of minor calyces or medullary pyramids most often. So usually this is where you're going to see them, typically, or you're going to see them in the UPJ or down the ureter. So what we are looking for on CT is pretty much this. Notice that you have your psoas muscles here and here, and we are still seeing a rib. So we're probably at the level of L1 or L2. And we've got our right kidney coming in. We're almost halfway through our left. And we see this big density here. That's typically what you're going to look for. We're not going to go into depth where this one is, because we really can't determine from this image. But the important thing to remember is that this is a stone. Typically, notice how the attenuation is. It's mirroring that of bone. And it's very different than what you're typically going to see through the kidneys. This is what a normal kidney will look like. This is abnormal. Here we have bilateral calculi in the UPJ. So notice that this is UPJ for both. This one has a more oblong appearance. We see that the kidneys are very small, and actually this patient may actually suffer from atrophy. Atrophy bilateral for both kidneys, because they're very small in relationship to the patient's body habitus. But also we see this one as well. Notice that it's smooth, and it's nice and smooth around, but it seems to be longer this way than it is this way. And so it's still an oval in appearance. I'd imagine that this patient is in excruciating pain. I notice that we have the renal pelvis is very much enlarged here. And so we have hydronephrosis as well, or hydropelvis. Let's say hydropelvis here. And so we have it on both sides. And so that is what the stone is actually causing here, a blockage in the pelvis as it's backing up into the kidney. Okay, this just demonstrates the benefits of a coronal image over sometimes an axial image. We have the psoas muscles here, and typically your ureters are going to lie around the psoas muscles. We have the kidneys here, and then it seems like we're tracing the ureter potentially coming here. We lose it. We have the ureter here, and we have the ureter here. And so this is what we're looking for. It's a stone lodged around the UPJ or UVJ going into the bladder. And so typically that's what you're going to look for. Let me clear clear these, and then we'll see here that we have a little bit of hydroureter here. So typically what we mean by hydroureter is that the ureter has urine kind of being pushed down in it, and it's dilating the ureter. And so that's what we're seeing here as well. One way that you can really keep, whether you're looking at a renal stone or you're looking at a phlebolyth, besides the oval and rounded shapes, is if you see any hydroureter, hydropelvis, hydronephrosis, things like that. That's what you're looking for, is things to be blocking and things are backing up. It's kind of like the And so you have a blockage and fluid is backing up, and that's causing dilation. That's what we're looking for. So then that brings us to a urinary obstruction. Urinary tract obstructions produce anatomic and functional changes that vary in regard to the rapidity of onset, so how fast it occurs. Okay. Degree of occlusion, so how much. And the distance between the kidney and the obstructing lesion. So all of these things will typically demonstrate how much of urinary obstruction you have. A blockage above the level of the bladder causes unilateral dilatation or dilation of the ureter, which is the hydroureter, and renal pelvic-testicular system, which is hydronephrosis. And so basically, these things are what you're looking for. And so if you are slightly above the level of the bladder, just what we saw with our previous image, we saw that we had pretty much dilation of the ureter, and so that's what we saw, and that's why we call it hydroureter. And so if you're looking at dilation of the pelvical calyceal system, then basically it's hydronephrosis, and all of these things are typically what we're looking for. And we see that they can be caused by urinary calculi, which is the most common, as we saw. But that's not to say that we can't have a pelvic tumor, urethral stricture, and enlarged prostate to cause all of these. So typically we think that it's urinary calculi, which is the most common. But you can have other things that cause stricture or occlusion as well. And so think about it. If you have a urethral stricture, meaning that your urethra is kind of blocked, you can't actually get your urine out. So it's going to cause your bladder to get full, and then because your bladder is going to get full, it's going to cause backup of the renal system. So it's very important to think that other things can cause this, not just a renal stone. So typically we're looking for a non-contrast helical CT to detect mass effects, stones, and other causes of obstruction, and it does it in a better way than an IVP. The reason that we favor CT is because, once again, not all obstructions are from stones. So keep that in mind, write that on your PowerPoint, that not all obstructions are stones. And so keep that in mind, put that away for future reference, because even in your clinical setting, we see such a prevalence of stones that we think that everyone is having a stone. And so that's why in the old days that we tended to go with an IVP. But think of all the things that were missed, because there can be things such as a mass or a stricture, and not just stones. So not all obstructions are stones. Keep that in mind. And so we see in non-contrast helical CT other causes of obstructions. Generally, it's demonstrated with an enlargement to the affected kidney, as well as dilatation to the renal pelvis and ureter. So you're going to see enlargement of the affected kidney and dilatation to the renal pelvis and ureter. So you're going to have the kidney get enlarged, and the renal pelvis and ureter kind of ballooning out too. So that's something to look for. Another thing to keep in mind is if we're looking for renal stones and we see a renal stone, typically we want to take measurements. Stones smaller than 4 millimeters, so it's 4 millimeter or smaller, nearly always pass spontaneously. So you don't have a warning when they're going to pass, but you know that they're probably going to. Stones of 6 millimeter pass about half of the time, so there's a 50-50 chance here that you're going to pass this stone if it's 6 millimeters. Stones larger than 8 millimeters rarely pass spontaneously, so there's going to be nothing that you can really do to get this thing to pass. Stones larger than 5 millimeters and located in the proximal 2/3 of the ureter are more likely to require lithotripsy or endoscopic removal. So basically, if we draw a ureter here, here's the kidney, here's the ureter, here's the bladder. So if you have a stone, let's say that this is 1/3, 2/3, and then this is the final portion. So if you have a stone that is in this area or above, and it's 5 millimeters or above, typically you're going to have lithotripsy or endoscopic removal to get it out. Because we go back to this, where stones greater than 6 millimeters pass about half the time, probably guaranteed that 50% that does pass, it's in the bottom 1/3 of the ureter. And so that's something to keep in mind, that this 2/3 rule. So keep that in mind. And what you're going to look for is the tissue rim sign. And so you're going to see, basically, you're going to see a stone, and then you're going to have what looks to be a little rim around it. And that's really going to tell you that there is an obstruction due to a stone. But also keep in mind that not all obstructions are stones. Here we have hydronephrosis or hydropelvis. Look where the stone is located. And so if we go by this reference image here at the bottom, we see that they have basically obliqued this patient so that we can see the kidney, and then we can see the renal pelvis and the UPJ. And so this is around the UPJ, where the renal pelvis is actually becoming the ureter. And so right here we have a blockage, which is causing a difficult time to actually go through. Also, notice that we have dilation here. It's more prominent. I wish that we could see the other side so we could have a reference point, but take my word for it that the renal pelvis is slightly dilated. Another thing to keep in mind is, probably the book will not show you this, but if I can actually get this to draw, notice that there's this thickened rim on the pelvis. Hopefully you can see it here. This thickened rim kind of leads me to believe that the patient may also have a bladder inflammation or cystitis, because there's a thickened rim on the pelvis. And so that would be very interesting to see the patient's urinalysis as well. See if there's some leukocytes in the bloodstream, in the urine also. So that brings us to a renal cyst. Typically, you're going to see over the course of your career several patients that have renal cysts, and or you may actually see a lot of patients that have renal cysts, depending on the type of area that you work in. And we see that simple renal cysts are the most common unifocal masses of the kidney. So they're the most common thing that you're going to see. A lot of times it gets people up in arms because you don't know whether they're malignant or benign. And you kind of have to go on the way they look. They are fluid-filled and usually unilocular, meaning that they pretty much don't have septations. So if you have this type number versus this, you definitely want to see this, not this. That's not something that you want to see. Sometimes septa may divide the cyst into chambers, which may or may not communicate with each other, and then this is what you have to worry about: is it malignant or not? They typically grow on the surface of the kidney or sometimes within the kidney. So typically going to be surface related. And up to 40% of people over the age of 60% of 60 years of age may actually have a renal cyst. So that's quite a large bit of the population. And so you may see a lot of patients that actually have this, or you may not see anyone that has it. Just kind of where your clinicals are and where you where you are as a tech. The causes of renal cyst is really unknown. We don't know what causes them. We don't know if it's just congenital abnormalities or if there is some triggering effect which causes the cyst to actually develop. It's much the same as ovarian cysts. We really don't understand what causes that as well. And so typically we don't know. It's kind of strange in medicine to say that you don't know something, but that's really where we are. We don't know what causes them. The associated symptoms, the good thing about a renal cyst is that many times there is no associated symptoms. The patient never experiences an abnormality or anything. However, some possible symptoms are pain in the side between the ribs and the hip, but that can mirror a lot of things. Pain in the belly or back, fever, frequent urination, or blood in the urine. So frequent urination, this might be inflammatory process. Blood in the urine can be a renal stone. Fever could just be any type of inflammation. Pain in the back or belly almost makes you think of an aneurysm. And pain in the side between the hips and the rib, I really don't know where that could be. It could be, appendicitis. It could be a colitis, Crohn's disease. All of these things could actually mirror the symptoms of a renal cyst. So many times we don't know that the patient has a renal cyst. It's kind of the furthest thing from our mind based on other symptoms. And so most renal cysts are basically an incidental finding. That's the good thing, is that typically you just kind of look up on them that they're there, and you just make a note of it, and there's really nothing that goes on beyond that. Therefore, there is really no workup for diagnosis. So basically the thing to keep in mind is most of the time you're not doing the scan for this. So usually scans not performed for cyst. So that's something to keep in mind. Usually exams will be ordered to evaluate for some other abnormality, with the renal cyst being an incidental finding. Once again, make a note of that incidental findings are usually what cysts fall into. Possible exams. Usually you start off with the CT, abdomen, pelvis. Cyst is discovered. If there is some abnormality or some reason for concern, then the other two exams will be utilized. Usually renal ultrasounds will pretty much demonstrate what the cyst is like, how much blood flow it's getting, if there is a cause for concern. And then MRI will be used to kind of demonstrate the attachment that it has to the kidney and kind of lay everything out. Usually MRI will be better utilized if surgery is required. So usually MRI equals surgical intervention. So usually that's the reason why an MRI will be utilized. On an unenhanced scans, the cyst has a uniform attenuation value near that of water. So we know that water has an attenuation factor of 0 Hounsfield units. So think about what bone has. Bone is white. Air is black. And water, well, it's going to be somewhere in the gray field. And so typically it's going to be one of these situations where you're going to see it kind of gray, but it's going to have a uniform attenuation, meaning that if you have a cyst, which looks something like this, and you take an attenuation value here, this attenuation value there should be equal. And so there should be the same density for the entire area. After the injection of contrast material, a simple cyst, I know this says simply, but this is supposed to be a simple cyst, becomes more apparent as contrast material is concentrated by the normal parenchyma. So basically what it's going to do, the cyst is not going to contrast, as we see that there is no change in attenuation value. However, it's going to become more apparent. It's going to kind of jump out at you because of the kidney actually absorbing the contrast material. And so it's going to really provide an interesting contrast. It's going to kind of make it stand out due to the fact that the kidney has got enhancement. So here we have a CT. Notice that this is with contrast, both oral, as we see here, and we have IV, as we see here. And notice that we have a kidney, right kidney here, and we're actually there's the left kidney as well. In this patient, it seems like the right kidney is actually sitting higher than the left kidney, which is kind of odd. But we see that we have normal renal parenchyma being in this area here, and then we see this big rounded density. Notice that there is no septations or anything, and that is typically what you're going to see with a renal cyst. Very classic symptoms of a renal cyst. The patient probably doesn't have any abnormalities of this renal cyst, probably wasn't even going in for a scan because they had a renal cyst. It was just an incidental finding. Okay, on this image we have much the same as we did in the previous cyst on the right side. We can see that because here is the liver. Notice that we have the cyst here, and then we have the right kidney, which we'll call the RK, there. And notice how we can see a clear delineation between the cyst and the kidney, and that's thanks to the IV contrast that we have. We can see the aorta is highlighted here, and the kidney actually has highlighting as well in the parenchyma, and so we can assume that this is a cyst. Notice that it has smooth borders and it does not contrast. Also, there is no septations in it. We don't see any divisions. It looks like one solid mass. That can be bore out even further by taking a density measurement here and then here, and then we can see that it's close to the density of water. Notice we have air here, and we have basically the inferior vena cava has a little bit of contrast in it, but if it had no contrast in it, blood would have slightly more density than water, but it'd be close to water. And so we could see that the cyst is pretty much what it implies, just a cyst and nothing more. Okay, so we've talked about cysts and one solitary cyst, but what happens when you have more than one? As the name implies, poly means many, and so many cysts on the kidney. And notice that this is a disease that causes there to be more than one cyst. On your right, or on your left side, you see that you have basically what is a normal kidney, a normal functioning kidney with normal systems. And on your right side, you see really not a normal kidney. You see all of these cysts located on it, and it kind of has a pebble type appearance. And so you have multiple cysts, and what does that do for the kidney? Well, that's what we're going to talk about. So polycystic kidney disease is also known as autosomal dominant polycystic kidney disease, or ADPKD. And so the thing to keep in mind is that it's autosomal dominant. Means that it's a dominant, not recessive trait. And so basically you have to have some person in your family have the polycystic kidney disease as well. Pass it on. And it's an inherited disorder in which multiple cysts of varying size cause a lobulated enlargement of the kidneys and progressive renal impairment. And so basically, the cysts become large, and then they result in renal impairment potentially. And 1/3 of patients with this condition have associated cysts of the liver. So sometimes you're going to have cysts of the liver which don't interfere with hepatic function. It is the most frequent genetic cause of renal failure in adults, and so that's something to keep in mind, that for patients, that's one of the underlying problems of renal failure, or the causes of renal failure, and it accounts for 6 to 8% of patients on dialysis in the United States. So 6 to 8% of patients, specifically on dialysis, are the result of polycystic kidney disease. Okay, also about 10% have one or more saccular aneurysms or cerebral arteries, which may rupture and produce a fatal subarachnoid hemorrhage. So you may actually have an aneurysm in the brain. So that's something to keep in mind too, that for some reason, for some unknown reason, polycystic kidney disease can cause this as well. And this is the most frequent genetic cause of renal failure in adults, accounting for 6 to 8% of patients on dialysis in the United States. That is another just a duplicate here, but it underlies the importance that that it is a cause of renal impairment, and potentially, if the disease progresses to a certain extent, it will cause you to go on dialysis. And so that's kind of a scary prospect for patients who have polycystic kidney disease. From now on, we'll call it autosomal dominant polycystic kidney disease, or ADPKD, and it's responsible for 6 to 10% of end-stage renal disease, or ESRD, cases in North America and Europe. It's approximately 1 per 800 to 1,000 people in the population carries a mutation for this condition. So notice that potentially there is a high incidence of people who can carry this around. And an early study estimates that approximately 70% of patients with autosomal dominant polycystic kidney disease will develop renal insufficiency if they survive to age 65 years old. So that's a high number, that 60% of the patients are going to develop a renal insufficiency, which they cannot overcome, and that is why you're going to have dialysis. And you're going to see a rapid increase in it, because if these patients do live to 65 years old, which with the modernization of medicine, that's not unthinkable now. It used to be probably in the 50s and 60s that 65 years old would have been considered a long life. However, with the modernization of medicine, we see that 65 is not really considered to be that long of a life now. And so we see patients exceeding this age, and that's why we're seeing probably a rapid increase in dialysis, because if the prevalence of autosomal dominant polycystic kidney disease is as high as what studies have demonstrated, then we're going to see a lot of patients go on dialysis to meet their renal insufficiency. One thing that you have to keep in mind is that it's an autosomal dominant disorder. It occurs equally in males and females, so there is no differentiation. Males and females both have it. And so therefore, each offspring has a 50% chance of inheriting the responsible mutation, and hence the disease. And so basically, you have equal opportunities here to actually get the disease. And approximately 85% to 90% of patients with autosomal dominant polycystic kidney disease have an abnormality on the short arm of chromosome 16. So that's something that you want to keep in mind. Make a star by too. That is chromosome 16 that typically has something to do with polycystic kidney disease. However, a second defect, termed ADPKD type 2, is responsible for 10 to 15% of ADPKD cases and is found on the long arm of chromosome 4. So star this as well. That most of the time it's an abnormality on the short arm of chromosome 16, but it can be an abnormality on the long arm of chromosome 4. So the way that patients present with polycystic kidney disease is, number one, they may have pain in the abdomen, flank, or back. But as we've discussed, many of these symptoms can be defined as other symptoms as well. So kind of nondescript. Pain, it doesn't really designate something over the other. Hematuria is frequently a presenting manifestation and usually is self-limited, lasting 1 week or less. So usually that it spontaneously occurs for no reason and then clears up spontaneously for no reason at all either. And so it's really kind of unexplained. And as renal failure progresses, patients may present with more classic symptoms of renal failure, such as a decreased urine output. And so that's typically what you're going to look for is a decreased urine output, glomerular filtration rate elevated, creatinine and BUN severely elevated, and that's going to be a deciding factor for the stage of renal disease. So how we diagnose polycystic kidney disease is kind of different. And you can order a lab test, a CBC or a complete blood cell count. And so this could show you if there is an increase in white blood cells, a decrease in red blood cells, things like that. It can really demonstrate to you if there is inflammation to be worried about. Urinalysis, that's going to show you what is in the blood. You may see some blood in the urine. You may see some leukocytes too. Urine culture, just to see if there's anything that grows, yielding an inflammation. But one thing that I didn't put here that you definitely want to write down is a comprehensive metabolic panel. And you're going to look for creatinine, BUN, and GFR. Typically someone who is going to have an increase in renal insufficiency, you're going to see a marked increase in BUN and creatinine and a rapid shift in the GFR to a downward trend. And so usually it's accepted for patients who have a GFR of 20 or sometimes it's even 30 and below. The patient is developing some degree of renal insufficiency. Remember that a GFR is the filtration of the blood, and if your kidneys aren't filtering the blood, then you're going to have an increase in creatinine and blood urea nitrogen as well. And so that's all something to keep in mind here. But usually we don't favor ultrasound. Genetic testing is not available everywhere. And so that would come later when you're wanting to see whether you have the potential to pass something on or what is actually causing it. But usually we favor CTs simply because that it's very simple to perform. We can get the results back. MRI after the CT, MRI and ultrasound after the CT has actually yielded some results, then prove very valuable as well. But CT, even CT without contrast, can yield a very diagnostic result for polycystic kidney disease. And then you begin or piecing the puzzle together. So basically, what it looks like on CT is that there's going to be the kidney demonstrated with multiple cystic areas that mirror the demonstration of simple cysts. So they're going to look like the cysts that we had previously saw, only that there's going to be lots of them. However, unlike simple cyst, a cyst that is hemorrhaging will be demonstrated with an increased attenuation. So you're going to see an increased attenuation, meaning that that a cyst that is hemorrhaging or experiencing a hemorrhage will look white or more white than others. And simply, the kidney will be covered with cysts. That's what you're typically going to look for. That's going to be your typical manifestation. And if some cysts appear to have a wider appearance, then it can presume that they are hemorrhagic and something to be worried about there. So I know that this is not a CT picture, but this is what a cadaver with both kidneys removed. This is what they look like. Here is cyst all over. Notice that there's this bumpy appearance. There's not a smooth outline, smooth texture to the kidneys. And it actually appears like the kidneys are even larger than what they typically normally would be. So this is what it looks like on CT. And it kind of makes you wonder how the kidneys can function at all once you see things like this. But we see this is the area that we're looking at, and you see all of these little areas. That is all cyst. I noticed that here and here and here you have normal renal tissue. It almost looks like this being the left and this being the right, that the left kidney looks much worse than the right kidney. Another thing to keep in mind is you see the liver here, and you actually see cyst in the liver as well. So this person has the triggering effect that has allowed the liver to gain cysts as well. We presume, based on there being calcifications here, that this patient is probably a little more elderly, or probably at least in their 60s, based on there being significant amount of calcifications in the arterial system. So here is another differentiation, this being the right side and this being the left. Once again, we see that the left kidney is huge and the right kidney is not quite as much. Here is the border between the liver and the kidney, and so if we look here, we see that we have cyst in the liver as well, pretty much all over the place. The right kidney and the left kidney are probably in their normal position, even though the left is really enlarged. But the thing to notice is you have this, this, and this on the right kidney, and so it's corresponding to a ureter cascading down, and you actually see it bore out that the ureter is functioning. So the right kidney still has adequate functionality for this patient. The cause for concern is we have the ureter for the left kidney here, and the ureter does not have a great amount of contrast in it, so possibly the left kidney is not functioning at all. And so we see that kind of bore out too, that there is not much normal tissue, and the normal tissue on the right has a certain degree of highlighting effect, whereas the left really doesn't. So it's potentially that this left kidney has completely or almost completely shut down in its filtration effect. So that brings us to one of the scary things that someone can see from a CT standpoint, and that is renal cell carcinoma. Renal cell carcinoma is also called hypernephronia. So something to keep in mind. And it's the most common renal neoplasm. It's the most common, and it can be very, very nasty in its disease progression. The thing to keep in mind here, and put a star by it, is that it occurs predominantly in patients that are older than 40 years old. The median age for diagnosis is 64. But the thing to keep in mind is that that is the age for diagnosis. It's not the time when you are in stage 1. This is when people find out that they are experiencing problems due to renal cell carcinoma, and so the disease can be very much progressive by that time. It often begins with painless hematuria. It begins with you just having blood going through your urine, but you don't know why, and you're not experiencing any pain. So oftentimes you just kind of disregard it, and then it progresses from there. The tumor usually originates in the tubular epithelium, the renal cortex, so associated with the renal cortex. Keep that in mind. That's where it usually begins. Renal cell carcinoma, or RCC, accounts for approximately 3% of adult malignancies. So, in the grand scheme of things, renal cell carcinoma is still kind of rare. In terms of cancer, it's not like lung cancer or colon cancer, where you have a high incident rate. You still have only 3% of adult malignancies. But the thing is that if you're going to have a malignancy of the kidney, it's probably going to be renal cell carcinoma, because it's 90 to 95% of all neoplasms arising from the kidney. This disease is characterized by a lack of early warning signs, and that's the scary thing is you don't necessarily have all of these warning signs that many other cancerous lesions kind of give you. You don't have these things until it's almost progressed to the point of being too late. And you also don't have one certain type of clinical manifestation, but you have a diverse range. So you have all of these different kind of clinical manifestations, and the problem with this is that many of these manifestations are other manifestations of other things, and so you attribute them to other things and stumble in on renal cell carcinoma. And the really, really horrifying thing is that typically is resistant to radiation and chemotherapy. Radiation and chemotherapy tends to not be as effective in this as it is in other cases. Typically what you're going to do, treatment involves a radical nephrectomy for the stage 1 renal cell carcinoma. So usually if you're in stage 1, you're going to have your kidney completely removed, and then you're going to have some degrees of treatment from that. The 5-year survival rate for stage 1 is 94%. So excellent survival rate for stage 1. Stage 2 have a survival rate of 79%. But notice that we have experienced a 15% decrease in just one stage. And so that kind of tells you where you're going with renal cell carcinoma. From 1975 to 2006, the incidence of kidney cancer rose 2% annually in the United States. So basically, the amount of people that experience renal cell carcinoma, or kidney cancer is a loose generic term, it has went up over the course of the years, each and every year. And it's more common in people of North America and North European ancestry than those of Asian or African descent. And so usually it's not those that are from Asia or Africa, but it's more along the people who are either from Europe or North America, or can trace their roots back to Northern European. So it's kind of unknown why this is. Really unknown. Renal cell carcinoma is the 10th leading cause of cancer deaths in males in the United States. In men, deaths from kidney cancer decreased 3.9% between 1990 and 2005, which is kind of crazy that the incidence of kidney cancer has actually rose up, but deaths have actually decreased. And so that kind of allows you to see that we've kind of made progression in terms of our treatment. In women, deaths decreased by 7.8% during the same period. So it's kind of an abnormality there. Why are men proving to be so less unresponsive to the treatments than women are? Could it be because that men have a tendency to ignore the symptoms longer, or is the disease progression greater? All of these things have a tendency to kind of adversely affect the type of treatment that patients get. But the thing to notice is that deaths have been decreasing while there has been more prevalence of people actually getting diagnosed with renal cell carcinoma. Unfortunately, and this is a huge unfortunate thing, the 5-year survival rate for patients with stage 4 disease are very low, from 0 to 20%. And we actually, at our hospital that I work at, we actually had a security guard get diagnosed with renal cell carcinoma. And the way that he discovered his renal cell carcinoma was very interesting, unlike probably any other story that you've ever heard. He was actually lifting weights, and he was lifting weights, weights that he had lifted, weight that he'd always lifted, no problems with it. And he was lifting it. I believe he was doing a bench press, and he was bench pressing, and he was pushing it up. And he hears this crack in the sternum area. And so doesn't really experience much pain, but he hears a crack, a very audible pop. And so he thinks that he's done something. He's cracked his sternum by lifting too much. So they come in and shoot just conventional radiography, and maybe a potential abnormality for a sternum, but no one can really tell. So they take him to CT and scan him. The physician orders the CT. It's a chest. They do it, and they see that his sternum has pretty much eroded. It just pretty much eroded away. And they're scanning through his chest, and they come down to his kidney, and his kidney has this large mass on it. And so, to make a long story short, he gets diagnosed with renal cell carcinoma, stage 4, and basically they do a radical nephrectomy. They put him on some experimental treatment, but by the time they get him on the experimental treatment, it has metastasized to his lungs. He has a nodule in his liver, and then his sternum as well. And so they're monitoring all of this. They have good progression. The disease seems to be decreasing. The nodules seem to be going away in his lungs. It seems like everything's amazingly working out. And so this is about year 2, and of that year, he comes in on Thanksgiving night, which I happen to actually be working, and he is having seizures. And so the ER physician looks at us, me and my friend who I worked with at the time. He looks at us, and he immediately orders a stat CT head. And so one of us have to go out there and kind of help hold him to the table, because once he actually came to, he was so disoriented that he was trying to fight everyone that was around. And so we get him on the table, and we do the scan, and we're reconning the scan through the head, and we're just seeing all kinds of just weird abnormalities, weird lesions through his head. And there's one behind his eye, and there's about 4 or 5 more throughout his head. And so ultimately, his eye that the lesion is behind, or the mass is behind, starts closing up, and all of this. And they put him on treatment, but within about 6 months, he passes away. So his survival rate was 2.5 years with stage 4. And ultimately, it wound up metastasizing to the brain as well. So usually this 20% is kind of a misnomer. Usually patients don't even make it to 20%. Usually there is very few that actually make a 5-year survival rate for stage 4. So that's what makes renal cell carcinoma very, very deadly. Survival factors. The following are factors associated with increased survival in patients with metastatic disease. Number 1 is a long disease-free interval between initial nephrectomy and the appearance of metastasis. So initially you don't have a metastasis, but you have a good span between the time that you take the nephrectomy out and then there's metastasis maybe 3 years down the road. And so that is a good survival tool. Also, the presence of only pulmonary metastasis. If you only have pulmonary metastasis, then you increase your survival rate as well. Also, good performance status. I mean that your body is in pretty good shape. Other than this, you have good renal function. Things like that will help bolster your survival rate. Also, removal of the primary tumor. So if you have the ability to have a radical nephrectomy, then typically you're going to be able to hopefully survive this, especially if you're in stage 1. So what causes renal cell carcinoma? We know that cigarette smoking doubles the risk of renal cell carcinoma and contributes to as many as 1/3 of all cases. So for some unknown reason, cigarette smoke tends to trigger renal cell carcinoma. We typically think of cigarette smoke only comprising lung cancer cases, but we see ultimately that it kind of balloons out, and that not only does cigarette smoke cause renal cell carcinoma, but it also causes, not only does it cause lung cancer, but it also can cause renal cell carcinoma. Very interesting. Obesity is another risk factor, particularly in women. As we see in our culture, obesity has began to take hold. And so it's not uncommon that we're actually probably going to see an increase in renal cell carcinoma simply because of this. Hypertension for unknown reasons, and phenylacetin containing analgesics. And who knows, the list could actually go on longer than this, but we really don't understand everything that there is to know about renal cell carcinoma. And that's kind of the scary thing. The associated symptoms, usually that there is a classic triad for renal cell carcinoma of flank pain, hematuria, and flank mass. But usually, this is uncommon. If present, it's indicative of advanced disease. So usually patients that have stage 1 renal cell carcinoma don't have this. So it's uncommon. 25 to 35% of patients are asymptomatic. Means it's just a finding that is really not what you were expecting. And that's kind of what happened with our security guard. It wasn't really what anyone was expecting. Just knew that something was wrong. The most common individual symptoms are hematuria, 40%, flank pain, 40%, maybe a palpable mass in the abdomen, maybe 25%. Weight loss is 33%, fever, hypertension, hypercalcemia, night sweats, and fatigue or malaise are all symptoms that you could have. But once again, all of these symptoms could go for something else as well. And so there's really nothing that points it to renal cell carcinoma or allows you to say, well, this is specific only to renal cell carcinoma. So the workup for diagnosis for renal cell carcinoma is a UA, just to see what's going on in the urine, CBC, and a renal profile, which is going to tell you things like BUN, creatinine, GFR, things like this to see really how the kidney is working. And so let's write that there. How renal system is working. Okay, CT is considered the most accurate. So that's something that we have going for us, is that it's the most accurate method of detecting local and regional spread of renal cell carcinoma. MRI and ultrasound, but usually CT and MRI are going to be what you're looking for. Ultrasound will really detect what kind of blood flow these lesions have, and it's very, very good, but it's not as good as CT and MRI in the grand scheme of things. So what does renal cell carcinoma look like? Large tumors greater than 3 centimeters are heterogeneous and multilobulated, and so they have different densities. And have septations. Enhancement is usually evident with an increase in attenuation in the range of 10 to 25 pounds-foot units. So basically, on your non-contrast scan and your contrast scan, on your contrast scan, you're going to see the density bump up around 10 to 25 pounds-foot units. And most enhance to different extents. And so you're not going to have pretty much everything enhanced to the same way, but because of heterogeneous densities, you're going to see them basically enhanced to different extents. Most appear as multicystic mass with non-communicating cystic spaces of varying sizes. And so that's going to be septations because they're non-communicating, and it's going to be multicystic. Also look for metastasis in lungs, mediastinum, bone, not boon. So this is bone. Liver, contralateral kidney, adrenal glands, and the brain. Okay, here is an example of renal cell carcinoma. You see that we have this region here, here, and the real impressive lesion is this. Notice that this is a simple cyst. So this is going to be simple cyst. Notice that it's the same uniform density, but we do see these areas here and here and here having some degree of contrast enhancement. Notice how the borders are really not easily defined. Let me erase. Okay, and so notice how there is no definable border here. Everything just kind of merges with the renal parenchyma. And because of this, we see that there is really no delineation between actual renal cyst or renal tissue and the mass. And so this is bilateral renal cell carcinoma, requiring probably, honestly, who really knows how this would bear out. You would take the worst one out and leave the other one in. So it would require a very radical procedure. So this is a very poor prognosis for the patient. But this is typically what you're looking for where the blue arrows are pointing. So this is more of a confusing image, probably. What looks to be very abnormal is just that, very abnormal. See that we have the liver here, and it's defined by this border. This is the falciform ligament, and then we have the left lobe of the liver here. Have the pancreas situated here, and we have the left kidney residing here, which looks totally normal, has good renal function. Have the celiac axis here, and then we have this, which the yellow arrow is actually pointing to what appears to be the renal pelvis. But this entire structure here is the right kidney. I'm sure just by simply looking at this, you can see that the structure is very abnormal. What we have here is diffuse wall of this structure, meaning that we don't actually have a clear border. And we see all of this weird structure laying out here. So we do see that we have some degree of septation there, and there is slight degree of enhancement here and here, but most enhancement there. And so based on this, we can presume that we're probably around the level of T12, and the mass has enlarged the kidney so to such a great extent that it is actually modified how the liver is sitting inside of the abdomen, and because of that, the mass has enlarged itself, and we have a weird border here. And pretty much everything is just classic for renal cell carcinoma. The good news is that it doesn't look like the left kidney has any abnormalities, and for this patient, that is a very good thing. This patient has a good right kidney, and then we have this on the left kidney. So we see that we have what looks to be a weird border, because we see that it's kind of lobulated, goes out like this. So that's one of our first signs that it's not just a nice smooth round cyst. Also, we see that it has encroachment of the parenchyma of the renal tissue of the left kidney. Also, to some degree, it looks like it has made some degree of enhancement, which would be slightly distinguishable around 10 to 25 Hounsfield units. We'd have to take measurements of this area before and after the scan to actually see. But I would say that it contrasts slightly. But this is what you're looking for. Your previous images are more of the classic symptoms. This one would be harder to decide whether it actually is or not. But notice that it doesn't look like a renal cyst. That's what you're looking for. Is that something doesn't look like a renal cyst? That's an, so you can see that that's an E. So there is a wide difference in between what a renal cyst looks like and what an abnormal renal collecting system with renal cell carcinoma looks like. And we have that here. So that brings us to Wilms tumor. Wilms tumor is also called nephroblastoma, and it's the most common childhood abnormality and malignancy that we have. And so notice and highlight that it is childhood. So typically it is what affects children. At the present, survival rates of children with Wilms tumor are approximately 80 to 90%. So there's a very good survival rate. And this is in contrast to the rate 50 years ago when only 10% of children survived. So thanks to modern medicine, they've actually increased the prognosis between 70 and 80% of what it used to be. And so virtually there's only very few cases where the patient would not survive. Wilms tumor affects approximately 10 children and adolescents per 1 million before age 15. So the standard is going to be before 15 years old, and you're going to have 10 children and adolescents out of 1 million affected. Therefore, it accounts to 6 to 7% of all childhood cancers in North America. In 5 to 10% of patients, both kidneys are affected at the same time, which is called synchronous bilateral Wilms tumor, or one after the other, which is metachronous bilateral Wilms tumor. And so it can either affect both at the same time or one right after the other. Wilms tumor is thought to be caused by alterations of genes responsible for normal genitourinary development. So it's caused or believed to be caused by alteration of genes. Examples of common congenital anomalies associated with Wilms tumor are cryptorchidism, a double collecting system, horseshoe kidney, and hypospadias. Cryptorchidism is where either the ovaries or the testes are not developed to a full extent. Double collecting system, we saw that before. Duplication. Horseshoe kidney factors in here as well, and those are the most common type of causation effects here, and that's simply because probably all of these have genetic anomalies associated with them, and because potentially these genes that affect them also affect the genes that cause Wilms tumor. The most common manifestation of Wilms tumor is an asymptomatic abdominal mass. And so the patient has an enlarged area of the abdomen, which is a palpable abdominal mass, but they're really not having any symptoms. Occurs in 80% of children at presentation. So a physician is going to be able to palpate or see an asymptomatic abdominal mass that's not causing the patient any problems. On those patients that do have pain, it's going to be abdominal pain, probably mid-abdominal pain, or flank pain. And then some patients are going to present with hematuria as well. So in certain situations like this, the abdominal pain and the hematuria typically are almost symptomatic of renal stones. So the workup for diagnosis for Wilms tumor, number one is a physical examination, which allows you to see a palpable abdominal mass. That's where this is usually revealed. Lab tests such as CBC, COMP, and UA can be diagnostic of a type of inflammation and how the renal collecting system is actually performing. A chest X-ray is just to be a baseline of what the lungs actually look like, and really it's not an indication of Wilms tumor at all. The only thing that you might see on a chest X-ray is the elevation of the hemodiaphragms, and you might see elevation of the lungs as well, but that would be all that you would see from chest X-ray. CT would be an excellent ideal to just kind of get a baseline of what that abdominal cavity looks like if you see a palpable abdominal mass. Then once you see the abdominal mass on CT, usually ultrasound and MRI are utilized. The only thing about MRI versus CT is that MRI is much more sensitive than CT for Wilms tumor and has a better diagnostic quality for it. However, the thing that you have to keep in mind when performing the MRI is the length of time while the patient is going to be in the MRI suite. And so if you're going to have the patient in there, and consider you're doing the examination on children, children will not stay still for a large amount of time. So that's something that has to be considered. MRI will be lengthy, and so there might have to be some type of pre-medication or sedation performed on the patient. So for the most part, CT aids in a very quick diagnostic quality, where an MRI and ultrasound can be further utilized. So let's look at the staging of Wilms tumor. Stage 1, the cancer is only found in one kidney, so it only is in one kidney, and generally can be completely removed with the surgery. And so basically, this, if you're going to have Wilms tumor, this would be the stage that you would want. Stage 2, the cancer is spread to the tissues and structures near the affected kidney. And so it's around tissues and other structures, but not in the other kidney. And it can be such things as fat or blood vessels, but can still be completely removed by surgery. Once again, surgical intervention can be effective on stage 2. Stage 3, on the other hand, the cancer is spread beyond the kidney area to nearby lymph nodes or other structures within the abdomen. It may not be completely removed by surgery. And so this stage 3 is when it gets a little iffy, whether the area can be completely controlled with surgery. Stage 4, the cancer has spread to distant structures such as the lungs, liver, bones, or brain. And so basically, it has metastasized, and you're experiencing abnormalities with the other areas as well. The brain would be very traumatic based on the type of structures that the brain is developing while you're a child, and that the cranium is still expanding and things like that. And so it can be a really detriment to cognitive development. Stage 4, cancer cells are found in both, or stage 5, cancer cells are found in both kidneys. So stage 5 is a very poor symptom because you have abnormalities in both kidneys. And as we know, we actually have to have at least one kidney in the body to actually maintain functionality. And so you're going to be presented with poor renal function, and things like that. But it really makes you wonder in a child how many patients actually reach stage 5, because as we know, children are growing, and you should be able to see that there's a large abdominal mass based on what we're going to see in terms of CT manifestations. So I would favor that stage 5 usually isn't reached, because you're going to see this mass hopefully before that. So here we have a patient, young patient. We have a kidney here. We have what looks to be bowel content here. It looks like there's some degree of motion throughout in all of these areas. And I noticed that the patient is kind of laying not flat, not decubitus either, but kind of at an oblique angle. But that's neither here nor there, because we see this large area here. And this is what we are calling Wilms tumor. And so this area here is all going to be the tumor. Notice how small that the left kidney is, and the right kidney is very much abnormal in this respect. But notice that to a certain extent, it's caused ballooning out of the abdomen area here. And so surely that this can be palpated long before it actually reached the higher stages. Notice it doesn't look like the left kidney is involved, so this definitely means that stage 5 is not a prognosis. We don't really know if any other abdominal structures are utilized and for metastasis, but we do know that stage 5 is not affected right now. Also, before we go into the next image, notice that this area is darker, this area is lighter. We kind of see that repeated with this area being lighter, darker, and this area kind of dark too. That is due to the differing degrees of contrast enhancement typical of a malignant lesion in the patient's body. Okay, this one kind of gives you a really good indication of a palpable abdominal mass. Notice how the abdominal wall is all nice and smooth here, and then on this side comes down and then goes out and goes back in. This would be palpable. And here you see that this involves the left renal collecting system, or the left kidney. Notice you have these areas of darkness like this, and then you have areas of contrasting lightness, and that is due to the contrast enhancement, which is caused by the malignant mass. So it's fairly obvious that this is a Wilms tumor. Notice the patient's body abscess is very small. This is a very small child, and so this mass should be very palpable. That's what you're looking for with a Wilms tumor. The mass is going to be very large, much larger than probably anything that we've actually saw with renal cell carcinoma, just based on the patient's body abscess. So that brings us to bladder carcinomas. Bladder cancer is the most common, or a common urologic cancer. Not the most common. Almost all bladder cancers originate in the urothelium, the 3 to 7 cell mucosal layer within the bladder. So it comes from the urothelium. Just keep that in mind. 70 or 90% are transitional cell carcinomas. 5% are squamous cell carcinomas. The development of squamous cell carcinoma is associated with persistent inflammation from long-term and growing Foley catheters, bladder stones, and possible infections. So keep that in mind, that 5% of all bladder cancer or bladder carcinoma cases are squamous cell carcinomas, which result from patients having Foley catheters placed in them. Sometimes bladder stones residing in the bladder without being evacuated very well, and possibly infections. So if you have a history of bladder infections or Foley catheters, then potentially a bladder carcinoma could be caused. Something that would be very interesting, study that would be very interesting to see performed would be patients who, and it would require a great deal of time and over the course of a lifetime, would be to monitor patients who have been paralyzed and have to utilize Foley catheters, and see if they have if they have an indwelling Foley catheter for the majority of their life. Do we see an increase in the prevalence of bladder carcinomas with them versus patients who don't normally have that? It'd be very interesting to see. Also, bladder cancer has the highest recurrence rate of any malignancy. So the problem with bladder cancer is that you get rid of it and then it comes back. Although most patients with bladder cancer can be treated with organ-sparing therapy, most experience either recurrence or progression. So the problem is, if you leave the bladder in after you've treated the cancer, due to the high recurrence rate, it's usually going to come back, and it could even come back with progression. And this creates a need for accurate and diligent surveillance. The American Cancer Society predicted that 70,530 new cases of bladder carcinoma would be diagnosed in the United States in 2010, and that 14,000 people would die from the disease. So we're not really given the fact whether these 14,000 people are going to come from that 70, but either way, if that's the case, then there's a pretty high majority of patients that are actually going to die from bladder cancer, simply that have been diagnosed. Also, bladder cancer is the 4th most common cancer in men in the United States after prostate, lung, and colorectal cancer. Whereas bladder cancer is not even among the top 10 cancers in women. So that's very interesting as well. While women tend to get infections and cystitis more so than men do, men have a higher incidence of bladder cancer, meaning that it's really common for men to get bladder cancer. And the interesting thing would be, would it be due to prostate cancer? Would that increase the likelihood of developing some form of bladder cancer based on the known treatments or things that will be in close proximity to the bladder? It'd be very interesting to see. Incidence of bladder cancer increases with age, with the median age of diagnosis being 68 years old. So usually you're around 68 when you get it, and it's about 4 times higher than men than women. So once again, men are going to tend to get bladder carcinoma more so than women are. And the recurrence rate of superficial transitional cell cancer, or TCC, of the bladder is high. As many as 80% of patients have at least one recurrence. And so what we're looking for is just the amount of recurrence. And the thing to keep in mind is that 80% of all patients let me go back. 80% of all patients with bladder cancer will have some type of recurrence, whether it actually is just simply a recurrence of what was there or it's going to be a progression. 80% of patients will have it. And so what causes bladder cancer? Up to 80% of bladder cancer cases are associated with environmental exposure. So usually it's things that you're around that will cause either some type of bladder cancer. Tobacco use is the most common cause. Once again, we typically think that tobacco only results in some type of abnormality for the lungs, but we saw that renal cell carcinoma and even bladder cancer do have, to some extent, some causation due to tobacco exposure. So it's one of those things that it's very hard to put down, but if you can rid yourself of tobacco use, then potentially you would maybe prevent yourself from being bladder carcinoma. Also, occupational exposure to aromatic amines or aniline dyes is presumed to be the cause of bladder cancer in up to 25% of cases. This can be diesel exhaust, petroleum products, and solvents. And so it would be very interesting to see if people who are around this, the majority of people who are actually some type of mechanic or oil worker, things like that, or do they have a higher incidence of bladder cancer versus the normal population, and to see how many of those actually wind up getting bladder cancer. That would be another interesting study. Also, exposure to organic chemicals has been reported as a risk as well. People such as beauticians, dry cleaners, painters, and others are even at risk for bladder cancer. So typically people that you don't even think that would be at risk for bladder cancer could potentially be. And so who knows actually what the end result will be for patients with bladder cancer, what we will actually come to the ultimate causation effect of it. So approximately 80 to 90% of patients with bladder cancer present with painless gross hematuria. Notice that hematuria tends to be what we see a lot, and this is called the classic presentation. So typically, patients are going to see just hematuria, and that's what it's all going to be about. Other symptoms include difficulty urinating or dysuria, urgency, meaning that you can barely hold your bladder, but a lot of times this gets with men. That's kind of gets swept under the rug as enlarged prostate. Typically, that's what sometimes it gets lumped into. Also, frequency of urination. That can go back to men and women. Frequency of urination. That's something that kind of just is assumed to happen as age progresses, but many times we often neglect what the symptoms are simply because we define them as being symptoms of something else. So one way that you can actually find out about bladder carcinoma is a test. You see what's in the urine. Cystoscopy. The thing about this is that it's low risk and that you can actually take biopsy specimens. But many times cystoscopy is not actually what you want to do initially. You want to work up to this. So this would come later. So you want to write later on this. Also, another thing that can be utilized is CT abdomen pelvis. This is what really is favored, and the American Urological Association recommends that this be performed with contrast. We'll find out in a second why it is, but if you don't have it with contrast, things have a tendency to blend in together. With contrast, you're going to see an abdominal, well, not an abdominal mass, but a bladder mass sitting inside of the bladder. Lastly is ultrasound. It's commonly used but can miss urothelial tumors of the upper tract as well as small stones. So has the potential to miss things, and you can't really see small stones. So that's why CT has a tendency to be better utilized and more prevalent here. So CT is performed with full distension of the bladder. That's typically what you're wanting. It's going to be very painful for the patient to hold their bladder, especially with the contrast enhancement. But you typically want as full of a bladder as you can so that you can see what the bladder looks like. Many times if you have not full distension but collapsing of the bladder with no urine in it, then it really doesn't work out as well. And you want to demonstrate a neoplasm as a mass projecting into the bladder lumen. And so what you're going to see is bladder looking something like this. I realize that this is a very crude drawing. You have the bladder wall, then you're going to see something actually inside of it. And so if all of this is filled with contrast, you're going to see an absence of contrast in this area as something is projecting inside of the bladder. It can be also demonstrated as a focal thickening of the bladder wall. And so you may see the bladder wall is thicker. We see that here the bladder wall is thicker than this area. And so that may be what you're looking for as well. Delayed scans show a soft tissue filling defect. So that's what you're going to see is a filling defect on a background of high attenuation contrast enhanced urine. So the urine is going to be bright white, and you're going to see this absence of it with something encroaching into the space. Here's an excellent example. We don't really have bladder wall thickening. The bladder wall is this white area here, and we see it coming around. And so this area can all be said to be the urinary bladder. The interesting thing is we don't actually have the right phase for contrast enhancement, but we see that we have something here residing inside the bladder. And so if we were to see a contrast enhancement phase here, we would see that this would all be white, and this would be kind of gray black, and so we wouldn't see white in this area. Another thing that kind of bears some looking into is, what is this in the rectum? We're really unsure of what this is. That could be free fluid. It would be very interesting to see what's going on there. This one is a little more descript. Notice that this is once again not a contrast enhanced bladder. This is in the initial artery phase. We see that here and here as we're going down the femoral artery. That's typically where you're going to see that the actual tumor enhances. And so this whole area here has shifted what looks like the bladder contents this way, and really caused a measurable decrease in bladder volume. And that's what a bladder carcinoma will do. Typically on your contrast enhanced arterial phase, you'll see the mass enhanced due to the fact of high amounts of blood flow to this region. But on your later scans, with your delay 5 to 6 minutes after the initial injection, you're going to see that the mass is probably decreased in attenuation value, and the bladder has actually picked that up. So your bladder is going to look white, and your mass is probably going to look a little dark. Once again, this is not this is the arterial phase, as we see it going down the femoral arteries here and here. But we do see that we have the bladder contents here being urine. So this is urine, and this makes up the rest of the bladder, and this is the mass. So a bladder Carcinoma is very difficult to miss. Usually, if you have any amount of urine in the bladder, it's going to be very easily seen. I saw a couple, well, actually probably 3 or 4 cases of bladder carcinoma, and they each look like this. Maybe not to the degree where they're that enlarged, but the patient does present with symptoms of dysuria, things like that, or urinary frequency. And it's usually in your elderly patients that actually have this. So that brings us to renal failure. So acute renal failure, or ARF, or acute kidney injury, or AKI, is, as it is now referred to in literature, is defined as an abrupt or rapid decline in renal filtration function. So all of a sudden the renal system just starts failing. This condition is usually marked by a rise in serum creatinine levels, or by azotemia, a rise in blood urea nitrogen concentration. Typically, a lot of people favor the serum creatinine levels over the BUN, because they say that BUN has a tendency to be affected by dehydration more so than creatinine. But it's also said that GFR is the best form that you can actually take to measure acute renal failure. So a rise in the creatinine level can result from medications that inhibit the kidney's tubular secretions, while a rise in BUN level can occur without renal injury, resulting instead from such sources as GI mucosal bleeding, steroid use, or protein loading. So a careful inventory must be taken to determine if a kidney injury is present. So basically what you have here between BUN and creatinine is there are some inaccuracies. They all have a tendency to be inaccurate. That's why it is essential that the patient be questioned to see if there are any things that can cause this, with there being no presence of renal failure there. Approximately 1% of patients admitted to hospitals have acute kidney injury at the time of admission. The estimated incident rate of acute kidney injury is 2 to 5% during hospitalization. So the scary thing is that maybe there's only 1% of patients admitted to the hospital because of acute kidney injury, but while they're there, 2 to 5% actually acquire acute kidney injury there. So the prognosis for patients with acute kidney injury is directly related to the cause of renal failure, and to a great extent the duration of renal failure prior to therapeutic intervention. On long-term follow-up, 1 to 10 years, approximately 12.5% of survivors of acute kidney injury are dialysis dependent, and it ranges from 1 to 64%, and depending on the patient population, and 19 to 31% of them have chronic kidney disease. Chronic kidney disease means that you're headed towards dialysis, where, let's write here, headed towards dialysis, whereas 12.5% are entirely dependent on dialysis, meaning that if they don't have dialysis, the amount of metabolic waste that occurs in the blood will not be filtered by the kidney, and they will have an accumulation of this and ultimately result in death because of not being able to excrete this. And so here are things that can cause acute or chronic renal failure. And so notice your acute is all of these boxes, and your chronic renal failure is these. And so we see that renal failure that is acute can be caused by such things as drugs, nephrotic syndrome, urinary obstruction, infections such as chronic pyelonephritis, malignant hypertension, autoimmune disease, polycystic kidneys, diabetes, and even malignancy. So all of these things can cause acute renal failure, meaning that it's not something that you have lived with, but it's something that you have good renal function and then all of a sudden you don't. Chronic renal failure can be result in the need for dialysis, transplant, or you can have anemia, skin disease, bone disease, metabolic disease, gastrointestinal disease, cardiovascular, nervous, muscle, and endocrine. So those are all complications of chronic renal failure. So the difference between acute and chronic is, once again, acute occurs suddenly, whereas chronic is something that you've known or dealt with over the course of time. So basically, the way this works is, in terms of renal failure, you have increased renal failure or renal failure, and then you have increased sodium retention, which, as we know, if you have basically have high sodium content, it's going to cause you to want to drink or retain more water. So you retain more water, and this retention to pretty much dilute what the sodium has done, or dilute the sodium concentrations to a normal level, will then cause generalized edema, meaning that water or blood is backing up. You're not able to excrete it because you're trying to balance the levels out. So the body thinks that it's doing something correctly, and then when you have generalized edema, then you ultimately put a strain on the heart, causing congestive heart failure. So renal failure can cause many things and can ultimately lead to congestive heart failure. So that is something that you have to understand, that you can't only treat one thing, but you have to look at all of the other things as well. You have to look at the possibility that the renal system is affecting the heart. And so the driving force for glomerular filtration is the pressure gradient from the glomerulus of the Bowman's capsule. The etiology of AKI consists of three main mechanisms. So you want to know these. You definitely want to put a star by these. The first is prerenal failure, and it's defined by conditions of normal tubular and glomerular functions. GFR is depressed by a compromised renal perfusion. Intrinsic renal failure includes diseases of the kidney itself, predominantly affecting the glomerulus or tubule, which are associated with the release of renal aberrant vasoconstrictors. Ischemic renal injury is the most common cause of intrinsic renal failure. And then post-obstructive renal failure initially causes an increase in tubular pressure, decreasing filtration driving force. This pressure gradient soon equalizes, and maintenance of the depressed GFR is then dependent on renal afferent vasoconstriction. So basically, prerenal failure is what you're going to say is related to other things. Other abnormalities of the body that actually cause the renal function to fail. Intrinsic renal failure is what you're going to say that there's an abnormality to the kidney itself, and post-obstructive is caused by things such as a renal stone, and so it's due to an obstruction to where the kidney can actually function, and because of that the kidney actually begins to shut down. And so all of these can be a causation of renal failure. So the associated symptoms are hypotension, volume contraction, congestive heart failure, nephrotoxic drug ingestion, a history of trauma or unaccustomed exertion, blood loss or transfusions, evidence of connective tissue disorders or autoimmune diseases, exposure to toxic substances such as ethyl alcohol or ethylene glycol, exposure of mercury vapors, lead, cadmium, or other heavy metals, which can be encountered in welders and miners. This is not supposed to have a 4 here, but Welders and miners have a tendency for renal failure based on what they encounter due to the toxic fumes. People with the following conditions are at a higher risk for developing acute kidney injury: hypertension, congestive heart or congestive cardiac failure, diabetes, multiple myeloma, chronic infection, or myeloproliferative disorder. All of these things can increase renal failure or be a symptom of it. So lab tests are one way, perhaps the best way to diagnose renal failure. You're going to look for BUN and creatinine, but also you're wanting to find the GFR, glomerular filtration rate. Once again, this is perhaps the most indicative form of renal failure, or indicative thing to tell you whether the patient is experiencing renal failure or not. CBC, just to look for any abnormalities in the bloodstream, such as high white blood cell count. Urinalysis, once again, to see if there's any proteins in the blood, to see if there's any leukocytes or lymphocytes, and if there's blood in the urine. Things like that will all be an indication for renal failure. And then this is kind of one of those things where you have to decide what you want to do. CT or an ultrasound. Once again, ultrasounds are user dependent, so we're going to write user dependent. Whereas CT really isn't. Also, there's a lack of availability of 24-hour coverage in some facilities, and so that is one of the strikes against ultrasound. CT, on the other hand, will possibly demonstrate a causation if there is a stone that is causing an obstruction, and that is an obstructive renal failure, then that will be entirely evident. However, one thing to keep in mind is that contrast injection should not be performed because all it's going to do is really impair renal function, and so potentially you're going to see GFR, creatinine, GFR go down, and increase in creatinine and BUN levels. And so it's one of those things where you definitely don't want to inject contrast because all it's going to do is really make the situation worse. So here's an example of a patient with acute kidney injury. Here are the kidneys, and there's really not much to be said for this image. We really don't look for renal failure in terms of CT. And one of the real confusing factors on this image is you have these little areas here, which look like there's contrast enhancement. And so we really don't know about this image. But the thing that we're really looking for in terms of renal failure is if there is a causation for the renal failure, such as a stone or things like that, or edema that could be caused by congestive heart failure, which is leading to the renal failure. That brings us to prostate cancer. Prostate cancer is the most common non-cutaneous cancer among males. Although prostate cancer can be a slow-growing cancer, thousands of men die of the disease each year. Prostate cancer is the second most common cause of cancer deaths in male. I know that one of the previous slides that we saw that regarding bladder cancer, that prostate cancer was the number one cause of male-related death. So there are some indiscrepancies here. Just know that prostate cancer is a very common cause of death among males. Prostate cancer develops when the rates of cell division and cell death are no longer equal, leading to uncontrolled tumor growth. And so basically, that's what you have with pretty much all cancers, where cell division actually starts going at an abnormal rate and cell death doesn't actually occur, and so you have abnormal tumor growth. And around 95% of prostate cancers are adenocarcinomas. So keep that word in mind, that most are adenocarcinomas. Approximately 4% of all cases of prostate cancer have transitional cell morphology and are thought to arise from the urothelial lining of the prostatic urethra. So they typically originate from the area of the prostate of the urethra that actually runs through the prostate gland. And an estimated 1 in 6 white people and 1 in 5 African Americans will develop prostate cancer in their lifetime, with the likelihood increasing with age. And so notice that for African American males, there is a tendency to actually have a higher risk of prostate cancer. It's really unknown why. The American Cancer Society estimates that 217,730 new cases of prostate cancer will be diagnosed in 2010. Prostate cancer is rarely diagnosed in men younger than 40, and it's uncommon in men younger than 50 years old. So usually the age to begin watching is 40, and it's actually even quite uncommon in patients usually 50 years and younger. So usually it's on the more older patients that you will see prostate cancer. Prostate cancer is the second most common cause of cancer death in males after lung cancer. So we see that prostate cancer is one of the most diagnosed cancers in males, but it doesn't result in as many deaths as lung cancer. Death rates from prostate cancer rose steadily from 1975 to 1991, then remained level from 1991 to 1994, and has decreased since then. So prostate cancer deaths are actually decreasing, and we have to imagine that that's simply due to the effects of modern medicine. Genetic factors. For example, the risk of prostate cancer is particularly high in people of sub-Saharan ancestry, while the risk genetic factors. For example, the risk of prostate cancer is particularly high in people of sub-Saharan African ancestry, while the risk tends to be low in many Asian populations. For some reason, the Asian populations really don't have an increase in prostate cancer. However, the really crazy thing here is that there is an increased risk in Asian people who have migrated to the United States. And so people who are in Asia typically have a lower risk of prostate cancer, whereas Asian people who actually come into the United States typically have a higher risk of prostate cancer. And this is typically assumed to be because of diet. People have assumed that there is an alteration on chromosome 1 and chromosome 17, and even the X chromosome have all been found to increase the risk of prostate cancer and to be transmitted among patients with a family history of prostate cancer. We also see that diet plays a role in the development of prostate cancer. Epidemiological studies have indicated a variety of dietary factors, particularly fat intake and obesity. And so that is one of the problems that we have run into with an increase in obesity and the amount of fat intake that we actually consume. We have been seeing an increase in prostate cancer, and that's due in large part to our diet. Hormonal causes have also been postulated. Androgen ablation causes a regression of prostate cancer. And this is because eunuchs don't develop prostate cancer. And so based on this study, we see that hormones do have a certain causation effect to prostate cancer. So currently 47% of prostate cancers are identified in patients who are asymptomatic. Really, 47% don't have any symptoms at all. Some symptoms include urinary frequency, just have to go all the time to the bathroom, a decreased urine stream, so basically you need to go
urinate, but when you do, you don't have much output. A urinary urgency, meaning that you really can't hold it. And then hematuria as 1.4%. Symptoms of advanced disease are weight loss and loss of appetite, anemia, bone marrow suppression, bone pain with or without pathological fracture, spinal cord compression, lower extremity pain and edema due to obstruction of venous and lymphatic tributaries by nodal or nodal metastasis. So all of these things come together and culminate in advanced disease. And so that's something that you have to be concerned with if you do start experiencing these symptoms. So lab test, the only lab test that's really believed to be useful is the PSA or the prostate screening antigen levels, and that's simply you have a range of what is normal and what is abnormal, and then if you see a marked increase in the PSA, then typically that indicates that you probably are at risk for prostate cancer. MRI, CT, they all have their moments that they are good and moments that they are bad. Sometimes in CT it's very difficult to demonstrate the prostate, much the same way in MRI, but it allows a better visualization. One of the big things is the transrectal ultrasound, which allows you to see the prostate pretty well. But once again, it's very difficult to really gain a diagnosis of prostate cancer. So usually what CT is used for is maybe just a quick visualization of the prostate, but we need to keep in mind that CT staging of the prostate is neither sensitive nor specific enough to be clinically useful. However, if we do use this, typical findings are going to be enlargement of the prostate, and maybe caused by benign prostatic hypertrophy, tumor growth, or both. So you could have enlargement of the prostate simply as a normal function, or it could be caused by tumor growth. Nodules or stranding densities in the periprostatic fat are signs of tumor extension, and the bladder could possibly have an indentation due to the enlargement of the prostate. Usually, this is what you're going to see: a bladder, an indentation, and possibly enlargement of the prostate outside of normal measurements. That's pretty much all CT can get. And so, what we're seeing here is the prostate. In all of these images, and typically what I think we're actually looking for is you see this increased area of low density versus enhancement here. That's typically what you're looking for, that hopefully will indicate some degree of mass, but you do see a prostatic calcification here in this image. But in terms of whether this is benign, malignant, whether there's something going on or not, we really can't see. This image kind of allows you to see that maybe there's something going on. You have what looks to be an extension of a normal, smooth, rounded area, and you have some stuff going on here, which presumably is extension of the fat. That's typically what we're going to say this is, but other than that, it looks like one homogeneous structure, and we really can't see what is actually going on. Okay, testicular cancer. Primary testicular tumors are the most common solid malignant tumor in men between the ages of 20 and 35 in the United States. For unknown reasons, the incidence of this cancer increased during the last century. So we've actually seen a marked increase in the amount of testicular cancer cases in the United States. The lifetime chance of developing testicular cancer is about 1 in 300. The risk of dying is very low, around 1 in 5,000. So
out of 300 males, one is going to get it. So the risk of testicular cancer is very high, but the deaths are pretty low. Testicular cancers are very sensitive to chemotherapy and are curable even when metastatic. Cure rates for good risk disease cure rates are 90 to 95%. There were approximately 190,265 men alive in the United States who had a history of cancer of the testes. So basically, there are a lot of people that are still living even though they have a history of cancer of the testes because of the 90 to 95% cure rate. Testicular cancers are not common, or not a common malignancy. Approximately 9,000 new cases are diagnosed in the United States each year. From 2002 to 2006, the median age of diagnosis was 34 years of age. So it's something for all males to consider as you approach the age of 34, that you're still not out of the woods for testicular cancer, and it can be found in varying degrees of patients. Various risk factors have been associated with testicular tumors, but the specific etiology is not known, so we really don't know what specifically causes testicular cancer. Possible causes are in patients with cryptorchidism, the risk of developing germ cell tumor is increased fourfold to eightfold. Crypt means hidden. Orchid is the ovaries or testes. In this case, it is going to be the testes, and it's going to result in undescended or hidden testes, which means that maybe they didn't develop either as well. First-degree relatives have a higher risk of developing testicular cancer than the general population. Although the incidence is low, about 2% of testicular cancer patients report having an affected relative. So there is some degree that if someone who is very closely related to you has testicular cancer, then there is a possibility that you could have it as well. Men with male factor infertility are nearly 3 times more likely to develop subsequent testicular cancer. And so there has to be a reason for the male infertility, and because of that, they have an increase in the risk of testicular cancer. So the way that testicular cancer is kind of found by symptoms is that there is a painless swelling or nodule of one of the testicles, and it's most common as the presenting symptom. So basically, there's an enlargement of one of the testicles, and it's really unexplained. There's no pain associated with it at all. So that's typically the most prevalent finding. There can be a dullness or ache or heavy sensation in the lower abdomen, which could be also a presenting symptom. Generally, though, men never know they have testicular cancer until they do a self-evaluation and discover a mass. So that's something to keep in mind, that we tend to talk about breast cancer and women doing self-exams, but it's in terms of testicular cancer, there's also a very important need for self-evaluation for men to rule out the fact that you have testicular cancer, because even though we do see that testicular cancer is very curable, up to 95%, there's still that 5% that falls through the cracks and actually winds up dying from the disease. So the need for self-evaluation is still pretty prevalent. So the workup for diagnosis is usually it begins with an individual self-exam. That's usually where the nodule is found, which prompts a physician examination, which should allow the physician to see whether there is an abnormality or not. This then prompts ultrasound, which is the primary modality for evaluation. Usually, ultrasound is all that you're really needing to perform. CT can be done, but notice that it's usually the CT of the chest, and that's to look for pulmonary metastasis due to testicular cancer. Testicular cancer usually runs to the chest first, and so you really don't utilize CT for the evaluation of testicular cancer, but only as a monitoring process for the progression of the disease.
So if you were to do a CT of the pelvis to see if there's testicular cancer, you see that there are pelvic and retroperitoneal adenopathy is most pronounced on the side of involvement. So usually you're going to see something on the side where the testicular cancer resides. And also you may see nodal enlargement near the ipsilateral renal column, and it's particularly characteristic. And so you may see some type of nodal enlargement, but that's all you will see with testicular cancer. So that brings us to the female reproductive system. And so notice that you have ovaries here, and then we have the fallopian tubes running into the uterus, which is this area here. And notice you have the endometrium here, the myometrium making a large portion of the outside. And then we actually have the cervix, which is this area here. And then we have the vagina going, completing the rest of the passageway. Sometimes this is going to be very hard to delineate between structures in terms of CT. It's going to be very hard to differentiate between uterus and cervix, and that's why ultrasound plays a very important role in terms of this, because it demonstrates structures much better than we can. But CT does still play a role in it. So one of the big things that you're going to see a CT on a female patient as having pelvic pain is going to be for an ovarian cyst. We see that an ovarian cyst is a sac filled with liquid or semi-liquid fluid or material arising in an ovary. Each month, normally functioning ovaries develop a small cyst called Graafian follicles. A mid-cycle, a single dominant follicle up to about 2.8 centimeters in diameter releases mature oocytes. So one thing that you need to take in mind is that each month cysts are developed. So even where there is no abnormality, there will be cysts. But normally these cysts pretty much go away after a specific point in the woman's menstruation cycle. The ruptured follicle becomes the corpus luteum, which at maturity is 1.5 to 2 centimeter structure with a cystic center. In the absence of fertilization of the oocyte, it undergoes progressive fibrosis and shrinkage. If fertilization occurs, the corpus luteum initially enlarges and then gradually decreases in size during pregnancy. Ovarian cysts arising in the normal process of ovulation are called functional cysts and are always benign. And so that's something to keep in mind, that if you have a cyst that was not there just a couple or maybe even a week ago, and then you develop a cyst, it's usually probably part of ovulation, and once ovulation occurs, it actually goes away, and it's usually a benign cyst. The number of diagnoses of ovarian cyst has increased with the widespread implementation of regular physical examinations and ultrasound technology. Ovarian cysts are found on transvaginal sonograms in nearly all premenopausal women and are in up to 18% of postmenopausal women. So keep this in mind, that cysts are not an abnormality to actually be seen in terms of CT or even ultrasound. Multiple functional cysts can occur as a result of excessive gonadotropin stimulation or sensitivity. Tamoxifen can cause benign functional ovarian cysts that usually resolve following discontinuation of treatment. So there are even drugs that can cause ovarian cyst production. But the real key is, what do patients experience as symptoms with ovarian cyst? Most patients are asymptomatic. So once again, you see asymptomatic kind of bore out here.
Pain or discomfort may occur in the lower abdomen. Usually it is in the lower abdomen or lower pelvic pain. Torsion or rupture may lead to more severe pain. Torsion is much the same way that male torsion actually works, and it can lead to very severe pain, almost meaning just someone slicing the abdominal cavity open without any anesthetics. Irregularity of the menstrual cycle can be another symptom of ovarian cyst. Abdominal fullness and bloating, and indigestion, heartburn, or early anxiety is all parts of maybe a symptom of ovarian cyst. So we see that the symptoms are very widespread and are really, you're not able to diagnose simply based on symptoms. There's lab tests that can be ordered, but we see that there are really no diagnostic values for any of them. Many times, though, patients experience the CA-125 test, which will help to define malignancy. However, I truly do dislike the CA-125 test, and most people do, because many times this will give both false positive and false negative results, and many times it is inconclusive. It's kind of devastating news to patients who get a positive CA-125 because they just all of a sudden think that they have cancer at some point in their body, even though nothing can be found. And sometimes it gives patients too much hope when there is a negative result, but it's a false negative. There's a lot of misnomers with this exam, and the CA-125 can actually be thrown off by things like infection or other abnormalities in the body. And so it's kind of undiagnostic. You really can't base everything on it. Ultrasound, once again, is the number one way to look at ovarian cyst. MRI is a close second. It's much more superior than CT. And then finally, CT, if you want a very quick exam with when ultrasound or MRI is not available, it will suffice. So normal ovaries are going to be seen as soft tissue masses approximately 4 by 3 by 2 centimeters in size. So if you see something around this size, it's typically normal. Normal follicles are thin-walled, low attenuation cysts, smaller than 3 centimeters in size. So you need normal follicles to be smaller than 3. Functional ovarian cysts are benign ovarian cysts, including follicular and corpus luteum cysts, and are common incidental findings. So this is going to be your most common incidental finding. They're well-defined, thin-walled, and have a homogeneous density near water. They're less than 3 centimeters in size, so they're going to be quite small and going to be equal in density or homogeneous. Benign cystic teratoma should have the presence of fat, density, fluid, teeth, bone, hair, or fat fluid levels. So these are going to be very interesting cysts. Notice that they have the presence of things like aiding in human development. So all of this would be totally normal. So here we have pretty much what would be just a functional ovarian cyst. Notice that we have a wall and we have a homogeneous appearance inside here. Notice that we don't see anything that's really abnormal. It's just an ovarian cyst on the right side. Most definitely this patient is probably experiencing right lower quadrant pain, and this is prompted the CT and we see the cyst. But notice that we don't have it, we can't really delineate what's involved and what is not if this cyst has invaded other structures. But thankfully we have contrast enhancement in the renal system. Got it coming down the aorta, and so basically we understand that this is performed with contrast and there's no degree of contrast enhancement, which means that this is pretty much a normal cyst. Here is something not quite as normal. And notice we have varying degrees of density inside of this.
And this corresponds to the axial image here, where we actually have pretty much this area, and then we have what looks to be fluid back here, or maybe this is still cystic in nature. And so this really illustrates the necessity of utilizing all types of reconstruction techniques such as axial, coronal, and sagittal. And so this one looks more complex. Really don't know what this may be, and even be questionable whether this is malignant or benign, due to the fact that there seems to be contrast enhancement going on. So that brings us to ovarian carcinomas. They're malignant lesions of the ovary, which include primary lesions arising from normal structures within the ovary and secondary lesions from cancers arising elsewhere in the body. Primary lesions include epithelial ovarian carcinomas, germ cell tumors, sex cord stromal tumors, and other more rare types. Mets to the ovaries are relatively frequent, and the most common primaries are endometrium, breast, colon, stomach, and cervix. All of these cancers tend to metastasize to the ovaries. In the United States, the incidence of ovarian cancer is 33 cases per 100,000 in women aged 50 years or older. The average patient at age of diagnosis is 57 years old, but that's not to say that you have to be 57 to get ovarian cancer. While the 5-year survival rate has improved, it remains low at 46%. Not quite where we want the survival rate to be, even with modern medicine. Studies have demonstrated that patients who have diabetes have a lower survival rate. As we know, patients with diabetes have a tendency to have more difficulties overcoming surgical interventions and things like that, and potentially this is why you have lower survival rates. The precise use of ovarian cancer, cause of ovarian cancer is unknown. Potential risk factors that seem to be linked are ovulation, and so we assume that it could be related to ovulation. It's increased in women who have not had children. Pregnancy reduces the risk of ovarian cancer by 50%. So patients who have not had children tend to have a higher risk of ovarian cancer. And once again, another interesting study that would be very applicable would be we've known for quite a while that women, for the most part, are delaying childbirth or having children, and so has this seemingly increased the risk of ovarian cancer? Are we starting to see more women have ovarian carcinomas? That would be something very interesting to see. Genetics. A familial history of ovarian cancer increases the likelihood of others developing it. So if you have a family member who has had ovarian cancer, then there's a possibility that it could be passed on to you. So that kind of makes us believe that there is maybe a strong genetic history for this. So symptoms of ovarian carcinoma. Physical findings are uncommon in patients with early disease. Patients with more advanced disease may present with a palpable pelvic mass, ascites, pleural effusions, bowel obstructions, bloating, abdominal distension, pressure on the bladder, constipation, vaginal bleeding, indigestion, shortness of breath. Usually you're going to have palpable pelvic mass, bloating, abdominal distension, and even pressure on the bladder as being classic symptoms of ovarian carcinomas. Once again, we see that lab tests sometimes are pretty much underutilized or not able to be utilized for a certain manifestation. And ovarian carcinoma is one of those as well. Once again, we see the prevalence of CA-125 to rule out whether there is a malignant or benign result. But once again, this test has such an abnormal reading or pattern that we typically don't think that it would be useful. Also, we have urinalysis, which to rule out any urinary tract infection. That brings us to bilateral mammograms, which if you have a history or you do have a known carcinoma of the ovaries, then usually breast cancer might be a result of metastasis here. Or if you have breast cancer, then you might get ovarian cancer. So mammograms are very important. Chest x-ray to see if there's any abnormality in the chest. Pelvic ultrasound is going to be your number one go-to, followed by MRI. And then CT as being the third option here. So the way that it looks in terms of CT is the primary tumor is usually cystic with thick, irregular walls, internal septations, and prominent soft tissue components. So this first bullet point is something that you definitely want to remember, as it will kind of allow you to see what ovarian carcinomas really are. Parts of the tumor should show enhancement when injected with contrast, providing a differentiation between benign and malignant masses. So you're going to look for tumor enhancement here. Look for direct tumor extension, commonly involving the uterus, colon, small bowel, and bladder. So it may actually have progressed into other parts of the body as well. So here we see, which is, we've got them labeled one ovary and another ovary. And we see that there is a septation here. And there's all of this kind of haziness, fatty deposits there. And this is what really gives us the clue that potentially this is a carcinoma along with this septation. That's really all that we can tell that might give us some indication here. This one is more definite, more easily defined as being a carcinoma. You're looking for this top number here. Notice you have a marked increase in contrast enhancement here. And then you see all of these little septations. All of this is typically what you're going to see or you want to bore out for ovarian carcinoma. All of this area. Here's another image at varying slices. We see that we have potentially could be free pelvic fluid here. So we'll say that this is P. We'll say that this is pelvic fluid. Then you see this crazy looking structure here with all of this in between. And notice that you have septations really here with decreased attenuation here, here, here. And because of that, that is typically what you're looking for as a malignancy. If you go over to image B, you have this huge mass. Interesting thing here is that it should be palpable, because notice that you have an abdominal wall kind of bowing out due to the enlargement of this mass. And so you're looking for contrast enhancement, which there is all over the place, with a decreasing density or hypodensity here in the center, corresponding to a carcinoma. That brings us to cervical cancer. Cervical cancer is the second most common malignancy in women worldwide, and it remains a leading cause of cancer-related death for women in developing countries. And in the United States, cervical cancer is relatively uncommon. It's the third most common form of cancer in the United States. The American Cancer Society estimated that in the United States in 2010, 12,200 new cases of cervical cancer would be diagnosed. The prognosis of cervical cancer depends on the disease state. In general, the 5-year survival rates usually are as follows. Stage 1, it's greater than 90%. Stage 2, around 60 to 80%. Stage 3, approximately 50%. And stage 4 is less than 30%. So you definitely want to catch it in stage 1 or 2, not stage 3 or 4. The American Cancer Society estimated that 4,210 women would die of cervical cancer in the United States in 2010. This represents 1.3% of all cancer deaths and 6.5% of deaths from gynecological reasons. Early research has provided a correlation between cervical cancer and sexual activity. So that's something to keep in mind, that sexual activity does have some type of bearing on cervical cancer. Major risk factors include sex at a young age, which we presume that to be due to the fact that the young body is still maturing and structures are still being fully developed, and because of that, they're not actually given a chance to develop. Multiple sexual partners, meaning that you're introduced to varying degrees of bacterial and other risk factors. Promiscuous male partners, meaning that who knows what kind of diseases may be introduced into the cervical area. And also a history of sexually transmitted diseases, which kind of mirror what we've already said. Multiple sexual partners and promiscuous male partners typically have a history of increasing the risk of sexually transmitted diseases. And we also found that HPV and the human papillomavirus or HIV really has a history of increasing the risk of cervical cancer in patients. So with cervical cancer, we see that there is abnormal vaginal bleeding, vaginal discomfort, malodorous discharge, dysuria, constipation, and hematuria. All can be really an indication of cervical cancer. The keys to diagnosing are, number one, Pap smear, so that you can really get an idea of what's going on. HPV test, as we saw, HPV increases the risk of cervical cancer, and so this can be an early way of diagnosing whether you could potentially have cervical cancer. Also, a CT, MRI, but also one thing that kind of got left off was ultrasound. So that is going to be your number one way of diagnosing cervical cancer. So if you were looking at it in terms of CT, you should see a solid mass behind the bladder, which should be enlarged with inhomogeneous appearance or contrast tissues. So you're not looking for homogeneous area. So you should see inhomogeneous or heterogeneous density. CT also has the ability to demonstrate if the carcinoma has invaded the pelvic side wall. And CT is not accurate when attempting to distinguish the cervix from the uterus and vagina. That's one thing that you're really going to have a problem with, and I would not even begin to question on an exam whether this is uterus or a vagina or cervix, because everything in terms of the structure tends to run together. And that's one of the downfalls with CT, is that we cannot distinguish between these areas because there's no density difference usually. So here we have pretty much the rectum here, the bladder being highlighted in yellow as this area, and then we have the small region of cancer. And so this is stage 1B, so a relatively small stage, pretty much indistinguishable. Here we have bladder being compressed, which would be one of the things that we could actually look for, and the rectum being pushed over to the side, and then a large cervical mass. That's typically what you're going to see, something to kind of take note of. But once again, it's very hard to distinguish what is actually a cervical mass and what else is going on. Here is a mass that is in the uterus. We have the uterus in here. We have enlargement here. We have the rectum here, and one of the things that kind of is tipping us off to maybe something abnormal is going on is the bladder wall seems to be encroached. It's kind of pressing on it, but that's not uncommon with the uterus, especially depending on what type of childbirths a patient has had, and if you have some abnormalities with the uterus already, that's not really uncommon. But we do see that there is some degree of enhancement here on the outside edges, which can just simply be the outside wall being enhanced. But it does seem to be slightly enlarged. But once again, we cannot diagnose this as being malignant cervical cancer. Okay, this is a PET scan. I noticed that we have a hot spot here. And because we have a hot spot there, that really means that there's a high metabolic activity. And because there's a high metabolic activity, that really means that this is a very concerning area, because there should not be a high metabolic activity there. And so that can be suspicious for cervical cancer. Here we see that this is labeled cervix, and we really don't know whether this is a cervical cancer or not. We do see that we have some degree of septation, but we really can't tell. If this is a cervical cancer, then this most certainly would be stage 1 due to the fact that